this was a really fun presentation to get ready for, because really had to reflect a lot on how we've been doing research in the space of pediatric headache medicine, and how I think that we can move forward as a field. And what I focused on discussing is that in the past, most of what we've done is borrow from what is being done on the adult side of headache research, and to kind of take an approach that's more investigator-led rather than really engaging with key stakeholders like patients, families, policymakers, in order to determine what our priorities are for research and to do studies in a very patient, family, and stakeholder-centered manner. And so, then I went on to discuss how I think we need to move forward in a different way in order to do better for our community. So first of all, children and adolescents with headache disorders are not exactly the same as adults with headache disorders for a variety of reasons that I went over, including possibly a bit of a different genetic loading for migraine. There's some research to suggest that younger onset of migraine, as an example, has higher genetic burden. We also know, and I'd like to joke that, my life has changed a lot since high school. I'm sure yours has as well. And so the child and the adolescent with a headache disorder or with any type of chronic pain lives in a very different context. There's impacts on the family, there's impacts on occupational planning, there's impacts on school performance. And so these are developmental considerations that we need to take into account from a social perspective. And then also biologically, we really don't know this, but I don't believe that a child and an adolescent with a headache disorder is exactly the same biologically as an adult, and that there may be differences in the disease at different ages. And that isn't based on a lot of evidence, but some emerging evidence from basic science that there may be differences. And also just knowing how much the brain changes from infancy to adulthood, and even into the late 20s, our brain is still developing. And so, different brain-based diseases are likely different at different stages of development. And we haven't considered that in our research in the past. And so, then I kind of moved on to discuss where I think we can do better in the future. So one thing is trying to address the issues that we've had with recruitment to studies, in particular clinical trials, by engaging in more collaboration, working on, having patient databases that are interested in participating in studies, doing more basic science work and, social context work to understand how headache disorders are different in the pediatric age group compared to adults, so that then we can focus on interventions that are more tailored for them and how the disease may be different at that age. And also, one other issue that I haven't touched on yet is that historically our studies have not been very diverse in terms of who gets enrolled into the studies. So we know that the majority, this has been looked at on the adult side in migraine trials. The majority of the studies in adult migraine trials haven't reported on race or ethnicity, and those that have are 75 to 97% white. We also know, based on general pediatric data, that, for example, Hispanic children are underrepresented in pediatric studies and Black children are overrepresented. And in the migraine space, that even getting a diagnosis, which will be required to participate in a trial, is less likely if you're male or Black, for example. So I think moving forward, we need to be aware that we haven't been enrolling representative samples of patients into our studies, and trying to really put much more effort in to doing better and enrolling people that are representative of our patients, not only from an EDI perspective, but we also kind of discussed in the presentation how we cherry pick our research participants. We exclude those who have psychiatric disorders, suicidality. We exclude those sometimes with developmental brain malformations, or those with daily or continuous headache patterns. And then not only are they excluded, but we tend to not do trials in those populations. And so when you look at the exclusion criteria for the current, migraine trials in the pediatric space, the majority of my patients would be excluded from them. And so we need to do better from an EDI representation perspective, but also just from a representation of what the patients who are seeing look like clinically from a disease perspective.